All right, good morning, everyone. Well, I'm going to have to make a disclaimer in the fact that I don't have any fancy toys to work with or fancy slides. So it's just me. All right. I'm going to start talking about immunotherapy, and I want to take us back to the beginning briefly in late stage disease. I know that this is not what this is about, but we really need to know where we came from. Focus then on the exciting area of immunotherapy and resectable disease, and touch on some research initiatives in stage 1 and as a preventive agent. So, stage 4 non-small cell lung cancer, when it comes to immunotherapy, there's only one class of agents that are approved, and those are the immune checkpoint inhibitors. That's an anti-PD-L1, an anti-PD-1, and an anti-CTLA-4 agent. And based upon these trials shown here, patients today have more options than they ever have had before. You can give an immune checkpoint inhibitor by itself, you can give dual immune checkpoint inhibitors, and you can give immune checkpoint inhibitors with chemotherapy. Now, the most important component of this slide is the fact that I'm showing you 5-year survival data. And before we had these revolutionary drugs, I'll take you back to just chemotherapy alone to where the average survival, median survival was 1 year, and the 5-year survival rate was about 5%. And you can see we are doing much better. And I will go further to say that we do know we are curing patients, albeit a small number, with stage 4 disease. All my medical oncology friends, we all have patients that are cured. Now, I put up their AGA, and you're probably going, what is AGA? AGA is actionable genomic alterations. We know that these agents do not work in those patients whose tumors have these actionable genomic alterations, EGFR being the prototype, but ALK, RET, ROS, HER2. Again, they have very low immunogenicity, and therefore they are not, they're contraindicated. Now, when you get to MET, BRAF, and KRAS, those do have a component that are immunogenic, and you can give immune therapy agents. And these patients typically have a smoking history. So that's really the key here for those actionable mutations on the far right. Typically, if they're going to respond, they actually were smokers, particularly we know KRAS and BRAF, and there is a subset of the MET. All right, so we have 2 pathways in lung cancer, those with and without actionable mutations. Now, we have not made any new advances in late stage disease beyond what I just told you, all right? And that's been several years. Now, having said that, we will get there. So many classes of agents, and within each class, there are multiple drugs being evaluated. And what I'm showing you here, I'm going to show you 2 classes of agents, which I think are currently the most promising in lung cancer. And the first is what we call bispecific monoclonal antibodies. And over there on the left, you can see ivonescimab. This is a bispecific to where one arm of the monoclonal antibody has an anti-PD-L1, PD-1, and the other arm has an anti-VEGF, an anti-vascular agent, okay? And you put them together in this one monoclonal antibody. And this is an agent that was developed in China, and you see 2 studies. Harmony A was the first study to be reported out. And this is a study that was in patients who had failed, who have an EGFR mutation. Remember, I just told you these drugs don't work in EGFR mutant patient populations. But when you combine it with a VEGF agent, and we do know this, that you do see activity. So there's a relationship between angiogenesis, PD-L1, mutations. So you can see that widely separated curve over there, all right? This drug is now approved in China for that patient population. And then Harmony 2, which was presented at the World Conference last September, was in patients who have PD-L1 expression greater than 1%, randomized to the standard pembrolizumab has really been at the top of the mountain in stage 4 lung cancer, but now it's challenged by this bispecific monoclonal antibody, ivonescimab, and they are awaiting approval in China for this. Now, in the United States, we're very excited about it, but because these trials were conducted in China, we need to see the results of a global trial for a future FDA approval. So that's very exciting. The second class of agents is really cancer vaccine. And this is going to be based upon the results from melanoma. Melanoma, where they looked at a personalized mRNA vaccine plus pembrolizumab in resected melanoma patients. And you can see the difference here. Those survival curves, the EFS curves are separating out there. And this is very promising. There's a phase 3 trial, InterPath 001, that's ongoing. And you'll see in a moment InterPath 002 in non-small cell lung cancer. And typically, again, I would say when it comes to immunotherapy, we have followed melanoma, okay? Completely different diseases, with melanoma being much more immunogenic, but we have been following them in terms of drug approvals. So we are going to be optimistic about this vaccine as well. But we have a whole group of immune agents that are in development. Now, moving there to stage 3, again, drug development starts late stage and moves its way up. We have what's called the Pacific regimen. And that is a regimen for unresectable patients who get concurrent or sequential chemoradiation, and then they get a year of durvalumab. Now, this has been the standard of care. We have 5-year survival data. Again, 42%. I mean, this is amazing. It's over 10 absolute benefit of over 10% here. So this is amazing. But we have learned some lessons over the last year that have been a surprise, that when you try to combine immune checkpoint inhibitors with the radiation and with the chemotherapy, no benefit. 2 randomized trials. I think we have been stunned by this, but now as we think about it, perhaps it makes a little bit of sense, particularly when you're radiating the mediastinal lymph nodes. We know lymph nodes are very important for the immune system. So we were trying to rev up the immune system, and then we were killing it with the radiation. So currently, we are looking at how do we build upon the core backbone of durvalumab and add other agents. And there are 2 randomized trials ongoing, although TIGIT, tiragolumab, I think these TIGIT agents are not going to be successful. This is a trial that I'm involved with. Beijing just discontinued their TIGIT program, and this is not the first one. So we'll see, but again, lessons learned. Now, this is really where all the excitement has been over the past 2 years, and that is taking these agents into the curative setting. Remember, cure is the goal. No matter what stage we're in, it is cure. So we always try to move our agents to the curative setting. And you can see in green the agents that have positive phase 3 trials, starting with the Empower study. This is giving atezolizumab after surgery, cytotoxic chemotherapy, the standard of care, and then atezolizumab for a year. Then we see Keynote-091, that's Pembro, all right, same design. And then Checkmate 816 is neoadjuvant, where we gave chemo plus an ICI, 3 cycles surgery, nothing else. And then Aegean, Keynote 671, and I apologize, I don't have Checkmate 77T on there. Now, these are just the different agents, durvalumab, Pembro, and nivolumab, all right? all positive perioperative regimens. You get the neoadjuvant chemo plus ICI, surgery, and then a year of ICI. All right, all positive. But we were recently humbled by the results of the Canadian group trial BR31 that was presented at ESMO. It was an adjuvant trial with durvalumab, stone cold negative. So a little surprising, but when you really look at the data, actually Keynote 010 and Empower 010, Keynote 091, the absolute survival was really small. So adjuvant therapy alone has really fallen out of favor, I would say, particularly now with one negative study, and particularly because we have the neoadjuvant trials, which are positive. Now, I'm saying it's fallen out of favor, but there are still patients that can benefit from an adjuvant approach. So I don't want you to think that you should never do it. You should in certain situations, all right? And it's fallen out of favor right now. Maybe if we can give the chemo plus the ICI, all right, remember, currently it's sequential, we might be able to bolster that immune response as we've seen in stage 4 disease. So there are 2 trials, Nadim and the Alchemist Chemo IO, that are going to give the drugs together. Those trials are ongoing. The one in red is the final adjuvant trial with nivolumab. So we've had atezolizumab, durvalumab, pembrolizumab. I know this is a lot. And then nivolumab. We're waiting for the readout. That is a trial that I've been involved with. And then here on that very far right is that inner path 002 with the personalized vaccine. Go to the operating room. After you get your operation, you've got lots of tumor, you can make that vaccine, and then you can get your chemo and then get the personalized vaccine. So I think that that's really very exciting. Well, here is the data for the neoadjuvant and perioperative regimens. A couple of points. There's only one neoadjuvant regimen here, and that's Checkmate 816. It is a very small study. Now, Keynote 671 is the only study that had a co-primary endpoint of OS. It was positive. Survival trumps anything else here. So perioperative regimens, we have 5. We have another one, the China Rationale 315, also a secondary endpoint, but positive for OS. And so currently the perioperative regimen is the standard of care, but then we just heard that the Checkmate trial did achieve an overall survival benefit. So now it's neoadjuvant versus perioperative. The question of the day, who needs perioperative IO? Now I'm going to skip this slide because it really isn't important here and go to this one. So the Checkmate studies, Checkmate 77T, the perioperative regimen, Checkmate 816, the neoadjuvant, identical eligibility criteria, all right? And so when you look at the survival curve side by side for those patients that actually got the adjuvant, you can see that at every milestone, the numbers are numerically higher for the perioperative. And then when an individual patient meta-analysis was done on the right, also does show a favor for the perioperative regimen. Now remember, this is only hypothesis generating. And when we looked at the clinical characteristics of the patient characteristics, really the only thing that stood out was pathological complete response. Whereas if you had a pathological complete response, you did not need probably adjuvant therapy. If you did not have that, you probably do need adjuvant therapy. And so there are several trials that are ongoing over here in the cooperative group setting, trying to look at who does and does not need the perioperative regimen. And I'm going to skip the other slide because I see I am also running out of time. This is a slide that's showing, so key point, how do we increase pathological complete response? Well, we do what we always do. We add more drugs. Is more drugs better? It seems to be the case. And there are some agents here that are looking very promising. I'm going to go to the bottom here of ivonescimab here with that 34% pathological complete response rate. So more to come in this space. Just a couple more slides. You've already heard that surgery is the standard of care for patients with respectable stage 1 disease. Maybe in the future it will be an ablative procedure as well. But how do we incorporate immunotherapy into this early stage 1? And I show you here that size does matter. If you go from 1 centimeter, 2 centimeters, 3 or 4, you do decrease that 5-year survival rate. So maybe we can incorporate immunotherapy, and there's one trial ongoing. What about unresectable disease, stage 1, 2 trials looking at SABR, which is the standard of care, combined with immunotherapy. 2 trials just reported out late last year. One of those happens to be my own study, despite really good preclinical data that we worked very hard on. It is a negative study that they have not been reported out, but hopefully we'll find a subset here. And then GGOs, we've talked a lot about GGOs. Now, the majority of GGOs are going to be those that have an EGFR mutation. They're going to be low immunogenicity, but there is a small subset that may have a little bit higher, more inflamed. And so here's just 3 articles on this, suggesting that there might be a window of opportunity for immunotherapy in this setting as well. And finally, in the prevention space, there is one trial ongoing with pembrolizumab, and then 2 studies looking at canakinumab in lung cancer prevention. Based upon this study of canakinumab, anti-inflammatory thrombosis outcome study in patients who had myocardial infarction, showing in the exploratory analysis that this agent was able to reduce the incidence of lung cancer. And so these trials are ongoing. I will say treatment with this agent failed miserably, but hopefully prevention might work. And so here are my take-home messages. Immunotherapy has revolutionized the treatment of non-small cell lung cancer, particularly for those patients who do not have an actionable mutation. At a plateau, but we will overcome that with many classes of agents in development. And that, there are windows of opportunities for stage 1 and prevention. Thank you very much.